Good morning and welcome to our 17th year of the Nurse Tech Symposium. I have no disclosure. The objective of this presentation is to give you the update on stent technology, including new coronary devices, as the effort continues to look and identify an ideal coronary stent. This presentation will outline the following, but the focus of the discussion will be on the salient features of these devices since they're still in clinical settings, and their clinical data and current status will be found in this article from the JACC, Coronary Stent Looking Forward by Garb and Ceruis. So here we go. 30 years of evolution in angioplasty. We all witnessed to the impressive benefits of drug-eluting stents, but we are still concerned with the safety because of stent thrombosis. Stent thrombosis is defined as a documented angiographic occlusion, either partial or total, of a stent after a successful procedure, or rather sudden cardiac death and post-procedural MI not related to any of the coronary lesion. The processes involved in stent thrombosis are multifactorial. It could be patient or lesion-related factors, patients presenting with acute coronary syndromes, unstable angina, patients with diabetes, low ejection fraction, chronic renal failure. And with lesion factors, we're looking at vessel size, lesion length, and arterial structures such as a tortuous vessel. It could also be procedure-related, whether there is a suboptimal stent expansion, malapposition, dissection, thrombus, or mechanical vessel injury, such as what happens when we have perforations. But part of the blame is centered on the device itself, and looking into stent thrombogenicity, referring to the material of the stent, the design, the surface coating, and adjunctive therapeutic agents. The next generation drug-eluting stents focuses on their design, the thinner the struts, bioabsorbable polymers, and pro-healing drugs, and up to most recently, the target of complete resorbable stents. This is a profile of the stent struts on stent platform from the first generation to the second generation stent, looking into the different drug types, the drug concentration and average coating of the thickness, as well as the strut thickness of the stent. Future generation is looking into a stent struts, but not currently available for use. This is under investigational study in the US and in Japan. The new durable polymer metallic stents is based rather on the knowledge and experience from the first and second generation stent, using new anti-proliferative agent, polymer technology, and thinner stent struts. The Elixir design uses a Novolimus eluting stent, which is a metabolite of sirolimus, has the same effectivity as the current drugs, but comes in a lower drug dose and load of polymer, which is conceivably safer than the first and second generation stent. The platinum chromium has an distinct advantage, which is twice as dense as the alloy of a iron and stainless steel, and because of that reduces the possibility of stent thrombosis, as well as the strength allows for rather thinner stent struts. Then we have a drug DES with biodegradable polymers, the Nevo stent design, which is an open cell design and with a unique reservoir that houses the biodegradable polymer and sirolimus mix that completely disappears in 90 days. And we have even the polymeric, non-polymeric drug-eluting stent, or polymer-free. The BioFreedom is coated with Biolimus A9, and the Vesta stent has a nanomicroporous surface that is coated with a very thin layer of sirolimus, and therefore prevents the trigger of stent thrombosis. The perceived advantages of this device are avoidance of adverse effect of a polymer's presence long-term, improved healing, improvement to the integrity of the stent surface because they don't fill up, and shorter duration of dual antiplatelet therapy. We have stents with noble coatings, the Genous stents. What is neat here is the presence of immobile surface antigen on the surface of the stent that binds with the endothelial progenitor cells and rapidly forms a functional endothelium, which is preventing, or rather prevents, the recurrence of arterial inflammation, which is a cause for stent thrombosis. This is an overview of biodegradable stent. Currently, we have 14 biodegradable stents, all mentioned in the article. But it's the Abbott bioresorbable vascular devices is in clinical trial in the United States, approved for clinical use outside, and more so in Europe. It is the backbone is made of polylactic acid, and the drug is everolimus. What are the potential advantages of bioresorbable vascular scaffold? They restore the vessel to a more natural state, capable of natural vascular function, eliminate chronic sources of vessel irritation and inflammation. The vessel remain free for future treatment options, reduce the need for prolonged dual antiplatelet therapy, and allows the use of invasive imaging techniques. This is the bioabsorption and drug release pattern of the bioresorbable vascular scaffold. The drug is completely resolved in 2 years. However, in the first group of this device, they found that when they follow it up with IVUS, that there was an increased decrease of luminal area in 6 months. Which they attributed to the loss of radial strength. So they revised, there was a revision made on the device, and they outfaced the zigzag pattern of it and connect it directly with the straight bridges, and the results are included in the cohort B of the trial. This is a direct confirmation of the disappearance of the struts. There's a baseline confirmed by optical computed tomography of OCT by baseline and 6 months. The stents look at the box, seemingly appears like a box appearance. And on 6 months of follow-up, you see the vessel, the lumen of the vessel corrugated with an incomplete opposition of the stent bridged by a tissue. And on 6 months, you could see the vessel clearly a smooth endothelial lining with the stents, the histology showing the disappearance of the struts. Then we have the self-expanding stents. This is the stents which is recommended now for the treatment of, or rather the stent of choice for patients that present with myocardial infarction. The thin, closely knit cells allows for trapping of the thrombus material to prevent distal embolization. And then we have the bifurcation stent, the dedicated bifurcation stent. We know that bifurcation lesions poses a challenge and high rate of stenosis because of the inability to trap the debris. Now they have come up with 3 groups of the stents: the conical stents for the geometry of the ostium, stents that facilitates the provisional stent, side branch stenting and maintain direct access to the side branch after the main branch stenting. And then we have the group, the balloon expandable dedicated bifurcation stents, stent designed to treat the side branch first, designed for those bifurcation lesions with significant side branch disease. A second stent is required for the main branch. Then we have the drug-eluting balloon, which is deemed to be a future, rather a healthy competition with drug-eluting stents. When drug-eluting stents cannot reach the target because of the tortuosity of the vessels in patients that have small vessels rather and calcified lesions. All current all the current drug-eluting balloons uses paclitaxel, which is an anti-proliferative agent that is absorbed in the smooth cell muscle and remains in the tissues, doing its anti-proliferative effect. It has the advantage of the absence of the polymer, which is ideal because it prevents vessel irritations. The stent struts disappears. Rather, it has thinner stent struts that allows the vessel to restore its vasomotion functions, and is indicated in lesions that are in stent restenosis, and currently it has an encouraging result in the use in peripheral applications, which our endovascular director Prakash Krishnans will discuss in our sessions today. In summary, no single stent design and polymer type will be suitable for all patients and lesion types. Stent selection should take into account patient characteristics, the ability of the patient to comply with dual antiplatelet therapy, and lesion characteristics such as the presence of bifurcation lesions. New stents technology appears to allow the interventional cardiologist to make these choices with the anticipation that they result into improved long-term clinical efficacy and safety. Thank you.